Diana from Aga Khan University, School of Nursing and Midwifery. Honored to have my teacher, Dr. Abdi, in the house, and you colleagues. So I will just give you a synopsis of my PhD thesis, which looked at health literacy of women diagnosed with breast cancer. And so that we can understand what we are talking about, health literacy is the ability to access, communicate, understand information in order to make treatment-related decisions. And then the cancer journey is the time from before diagnosis, during treatment, and post-treatment. So that's the outline of my presentation. For introduction, just a little background that 80% of the global breast cancer burden is in the low-middle income countries where Kenya lies. And literature has shown that 80% of the breast cancer patients are diagnosed in the late stages, that is stage 3, stage 4. And literature has also shown that there are factors that affect or influence health literacy. So studies have been done in the West about health literacy, but in this part of the world, little has been done. And that is what informed my choice to conduct this study. So the purpose of my study was to explore the health literacy experiences of women diagnosed with breast cancer, and also to find out the factors that influenced how they accessed and used information to make treatment-related decisions across the cancer journey. So from before diagnosis, during treatment, and after treatment. I did a qualitative study, longitudinal. Study sites Kenyatta National Hospital and Aga Khan University Hospital, women who are attending the oncology clinics. Purposive sampling of 11 breast cancer patients, 5 from Kenyatta, 6 from Aga Khan. And I did semi-structured interviews using an interview guide. So longitudinal, so I interviewed the women at 3 times, so with intervals of 6 to 4 weeks. So data analysis thematic, and I also used in vivo to organize. So what were the findings? So 3 major themes. What were the sources of breast cancer information? What were the information needs of the women who have breast cancer? And what were the factors? So if you look at that slide, there are our common sources, but very interestingly, if you look at the last 2, sources of breast cancer information, something interesting was that the church came across as a very, very major source of breast cancer information. Most women said that they learned about breast cancer from their church meetings, from their church groups. The other thing is the social networks. When women go for their groups, the chamas, that's when somebody talks about breast cancer. So this actually has implications going forward, that our opinion leaders in church, opinion leaders in chamas also need to be empowered with information so that they can pass the correct information to our women out there. Then information needs. And I know from our practice, there is one standard information booklet for all patients. What came out was we need to individualize information. So patients want to know about the treatment. Yes, I'm getting chemotherapy. So what is this chemotherapy? And I remember one woman who said, when the nurse comes, she tells me about, the pre-treatment. So she tells me, we are giving you this normal saline. But when it is the actual chemo, they ask you to read with them. So it frightens the patients. They are like, what is this? Is this poison? So we need to actually explain to them about the actual treatment, the causes, how many times they'll come, side effects, coping with side effects, and the side effects were a major cause of distress. Women just found themselves, in the morning you wake up, you don't have hair. And our hair is our crown as women. So it was so distressing. We need to tell patients about our the side effects, diet, follow-up, survival after completing treatment. So patients were like, after I finished treatment, I was just told to go. And I didn't know, so what happens? They were not told you need to keep coming to the hospital. You need to keep seeing the doctor. So some of them stopped coming for their appointments, okay? Factors. Breast cancer awareness. Prior breast cancer awareness was a major factor. So people who had relatives or friends who had breast cancer actually perceived the information much better and they utilized it. And then attitudes towards breast cancer screening. Breast cancer is not only breast cancer, but all cancers are perceived as a death sentence. And that came out in the transcripts, that when I was diagnosed with cancer, I saw death. I knew that I would die. So, you know, the fatalism, the feeling of hopelessness that comes with the cancer diagnosis affects how they receive information. And then what happens? You break the bad news, you have a cancer diagnosis, and already you start telling the patient the treatment plan. So at that time, they are so emotive, and what they said is the last thing they had from that session was the word cancer. So you are there as a doctor, as a nurse explaining, you'll have chemotherapy, you'll have surgery, but the patient is thinking about, oh my God, I have cancer. So they are actually not understanding anything. At this point, I want to point out that Kenyatta, the patients from Kenyatta had actually a better experience than Aga Khan. And I'm not saying this to demean, because Kenyatta patients, they said after the diagnosis, they go through counseling. So the patient and the family meet a counselor who informs them about the disease and the treatment before they start the treatment. So they actually had a better experience. Medical jargon was big. Patients were speaking medical jargon. And then what happens is, as care providers, when a patient speaks medical terms, we assume that they know. The truth is they don't know. They're just repeating the medical jargon that we talk about. So they will talk about grading, staging, fish, cycles, but they really did, when I explored further, they could not explain what that means. And then social capital, a very important factor. Social capital is simply, who do you know? So patients who had medics in the family or friends who are medics actually received information better, and they actually could go, they knew there was screening, they would go to screening camps, and that. And then institutional policies have captured a little bit of that, like Kenyatta, and also the bit about NHIF. That borders more on governmental policy. So NHIF, people who could not afford to pay, I mean, they defaulted. There's a lady who actually had to be contributed for by the nurses and even other patients because she had defaulted her treatment. So from this study, we see unique information needs for each patient. Factors that affect health literacy are multidimensional, but interestingly, finances came across. And patients were saying, yes, you'll give me information, but if I don't have the money to pay, that information won't help me. So these factors that I have talked about may actually be the root causes of the perceived low health literacy and not low health literacy per se. So these have implications for both practice, policy, education, and research as presented there. And my recommendations are that in a low resource setting like Kenya, these factors actually need to be looked at when we are disseminating information. Thank you very much for listening.